Good evening. We are very excited that you are joining us for MAiDHouse's first virtual event. We are going to explore the topic of access to MAiD in the age of Bill C-7. If you could just take a moment to look to your side at the chat, we have a couple of acknowledgements. One is that about how we will go about exploring the issue and being respectful to each other, and the other is a land acknowledgement. I would just like to take a moment to acknowledge, as a virtual event, we span many traditional territories. For the host of this meeting, I'm on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home of many diverse First Nations and Métis people. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. It is my pleasure to now introduce you to Karen, who is going to take over moderating the event. Karen Wells has been recognized as one of Canada's leading documentary makers. Her work has been frequently heard of on CBC's radio Sunday morning, and over the course of her career, she created 6 documentaries on medical aid in dying in Canada, Belgium, and the United States. And we are very honored that she's bringing this expertise to help us facilitate our discussion and our panel. Karen Wells is also a 3-time winner of the Canadian Association of Journalists Documentary Award for Investigative Journalism. Her work has regularly won international awards and has been recognized by the United Nations. And she's been using this expertise to help MAiDHouse develop our first virtual event. And we have benefited greatly from this expertise. She's regularly asked to speak and moderate at events throughout the country. In 2011, she was introduced in the University of Ottawa's Common Law Honor Society, and in 2020, she published The Abortion Caravan: When Women Shut Down Government in the Battle of the Right to Choose. I hope you enjoy the evening. There'll be opportunities for questions and answers at the end, and I look forward to a lively discussion.
Thank you, Tekla. There, okay, over to me. Thank you, Tekla. Welcome to everybody. We have participants and audience principally from the Toronto area, I think, tonight, and some from Northumberland County. I'm in Port Hope at the moment. So, and I mention this because there's a difference between MAiD in an urban environment and MAiD in a slightly more rural setting. And we may reflect on that a bit as the evening goes on, we may not. This is how things will work this evening. Our speakers will have the floor till around 8:30, 8:40, and then the last half hour will be devoted to questions from you, from the audience. And I'll mention this up front because it's good to start thinking questions you might want to ask. And the way we'll do it is you type the question in as succinct a fashion as possible. It's a question, not a speech. And in the Q&A function. And then the questions will come to me and I'll pose them to our panel. And I'll do a reminder of that as we go along. So we're back to, I want to start with our speakers for this evening. In a few moments, we will go to our panel. And our panel is made up of a lawyer, a MAiD provider, and the CEO of one of Toronto's largest hospitals. But we want to begin with 2 people who have had direct experience of access to MAiD, of how that works or doesn't work, and the difficulties therein. Vicky McAuliffe's husband received MAiD, I think, about a year ago. He suffered from Huntington's disease. Mark Somerville's mother was a cancer patient, like the majority of people in Canada who receive Choose MAiD. Mark, can I start with you? Now, where are you, Mark? Are you there? Yep, there you are. I think you're on mute. Good, you're no longer on mute. Tell me, please, what were your mother's circumstances? what led her to the point where she made that decision that she wanted MAiD?
In August of last year, she was diagnosed with stomach cancer. So she had stomach cancer, and she'd also suffered the loss of her life partner the year prior. So she was dealing with progressively, the progressive cancer that was, going to be getting worse, in addition to a broken heart from the loss of her life partner. So that's what brought her to exploring the options for MAiD. She was 85, 86 at the time. And, her health was deteriorating. She couldn't move around as much. Her mobility was being affected. Her mental acuity was still pretty sharp, but definitely her independence. And my mom was a very fearlessly independent woman and loved her freedom and mobility. So the loss of these and the progression of the disease of cancer as it continued, and the treatments and the radiation was seriously impacting the quality of her life.
And she was deemed eligible for MAiD, and that was the choice she made.
Mm-hmm.
Did she speak about where she wanted to die?
On a beach, actually. But
Not
she was really torn because, in the beginning of the process, she kind of said she just wanted to like go crawl off somewhere and die alone. And it was really quite sad to hear as her beloved son. But she had recently moved into a house that wasn't really a home, kind of a dilapidated stepping stone to, the next stage of her life, whatever that was going to look like. And it didn't feel like home. It wasn't comfortable. It wasn't homey. And she told me, the last few months before she died, she had almost never hated a house, but only two in her life. One that I grew up in as a kid for like a year, that was quite horrible. And then this place. So she didn't want to die in that house. She had no emotional connection to it. It really wasn't a good environment. And for her whole life, she hated hospitals. The hospital was like the last place she really wanted to go. She didn't like going to the doctor. She liked hospital food, mind you, but she didn't like hospitals. So that was unfortunately the last resort. We had explored with the providers and social workers and different organizations what other options were there. Like, could she go to a hotel? Could she go to a nice 5-star resort? Could she go to a beach? Could she go to somebody's home, like a family member's home? And at the time, none of those options were doable.
So, I think it's about a third of people who choose MAiD in Canada do die in hospital, but that wasn't what your mother wanted to do. So
correct.
You were stuck, and ultimately that is where she died. How did you make it work for her?
Well, we did the best we could. As I mentioned, initially she wanted to just go off and die alone, and with some gentle prompting and encouragement, she came around to having her close family there. And in the end, we had a celebration of life in the hospital room. She had a private room. We decorated it with balloons, flowers. We drank champagne the night before the procedure. We danced, we sang. My brother played horn. So it was quite out of place in a hospital setting. But it was my mom's last night on earth. So we did the best we could under the circumstances.
What would you have preferred?
Definitely a home. I mean, the house, she lived in a house out in Scarborough, east end of Toronto, for 28 of the last 34 years of her life, 33 years. And that was home. Like, she had gardens, she had a studio in the back where she did her paintings and her craft work. She had her piano, a fireplace. Like, every seasons, the decorations would change, and she would, it would be
She was happy
resplendent
there.
with,
Yeah.
yeah, it was just a beautiful, warm, inviting. She hosted people all the time. So that kind of home-like, comfortable setting would have been the perfect place to do it.
But that wasn't to be.
Correct.
Thank you. Thank you for telling that story. Greatly appreciated. And I'd like to invite you to be part of our panel as we go along, if you choose to, and to listen in as you wish. But I'd like to turn at the moment to Vicky. Vicky, are you there?
Thank you for having me.
Vicky's camera will turn on in just a moment, and her microphone. There she comes. Thank you very much, Vicky. Vicky, your husband, I know, suffered from Huntington's disease, an inevitably progressive disease for which there is no remedy, no cure. When was he diagnosed? How long ago?
About 30 years ago.
A long time.
His father had it. So therefore we watched his father decline, and that's why he chose not to go there.
Right. Back then, MAiD was not an option. When did he start to talk about wishing to die on his own terms, as it were? I mean, was this always in his contemplation?
Always. So right from the time he found out he had the gene, we started talking about how he could die as he wanted to. So that might mean going away. It might mean going to another country. So we were investigating on a continual basis.
But the fact that he was so ill for such a long time, that affected every circumstance of your lives together, did it not? I mean, it tapped your financial resources.
That's right. Completely. So we, yes, I couldn't work because I was depressed, and he couldn't work because he had Huntington. So my pension was spent by the time we were 60, and his was just, well, and then we had to sell our house. We had to sell all our furniture, everything. So somebody gave us, Michael by this time had been approved. And I happened to have a part-time job and dropped in to see if a friend still lived at a particular address. Hadn't seen her in 30 years. And she said, "What do you need?" I said, "I need a house and I need some place for my husband to die." And she said, "Come on in." So it's very unusual.
And you did not have the option of, he could not have MAiD at the place where you had been living. That's correct? Because the landlord wasn't comfortable with that.
That's right. It wasn't nice either. It wasn't a nice place. The last one wasn't a nice place.
Right. Same thing that Mark spoke about, not a congenial atmosphere. Yeah. So ultimately, it was the friend who offered her place.
Right. But we did manage to go back to the condo that we used to live in for 15 years. And they gave us the party room for free. And so all of our families and friends, even our doctor and optometrist, came to give him a hug and say goodbye. So it was quite lovely. It had a lovely garden as well. So it was very, very nice.
So people do come through and help a great deal. Yeah. Did you consider, and he consider, a hospital?
Never.
Setting? Never. Why not?
It's not a very nice place. And the other problem, I've had several people that I've talked to since who had a very hard time in the hospital, because if it's someplace like St. Elizabeth, it's religious, and no nurse, the doctors didn't want to do it because of their religion. So you ran into that. There was one chap who the doctor was willing, but the pharmacy wouldn't give him the drugs. So it got complicated. But if it's outside the hospital, it wasn't complicated.
And the last thing you needed at that point was complicated. Right. Thank you again for telling this story. Greatly appreciated. And I'd like to invite you, as I did Mark, to stay with us and chime into the panel if you choose, and otherwise stay to the side and watch. But we'll move on now to the panel, and I would like to introduce our panelists to reflect on the circumstances that Mark and Vicky have described, and to look at how access, both in physical sense and the legal sense, has changed or not with the introduction of and the passage of Bill C7. So let me introduce our panel. Our lawyer on the panel is Clancy Catalan with Rose and Sunshine, a newly minted lawyer with a strong background in health law and ethics. She has been watching this legislation carefully and has worked on various regulatory measures with different healthcare professions. That's pretty accurate, Clancy?
Yes, it is. Thank you, Karen.
Great. Okay. Joining us as well as a MAiD provider is Dr. Chantal Perrault, family physician, psychotherapist, and has been a MAiD provider since 2016. And she is also, I should mention, on the council that advises Dying with Dignity and chair of MAiDHouse. Welcome, Chantal.
Thank you.
And our third member of the panel is Heather McPherson, who is CEO and president of Women's College Hospital. She began her professional life as an occupational therapist. So she's a clinician who is also a manager. And I think that makes you a bit of a rare bird in the world of healthcare, having both those functions. She's also chair of the board of Planned Parenthood of Toronto. Good evening, Heather.
Good evening, everyone.
So thank you all for joining us. I want to start with Clancy. Clancy, could you give us a thumbnail of the major changes in the new amendments? And it's worth pointing out that these are amendments and changes to the criminal code, because what we're dealing here with is exemptions to a charge of murder. It's very serious stuff. So what has happened?
Absolutely. I do think it's interesting that you raise that, because I think it does inform the way that the changes are made and the way that the provisions are written, in that they're not so prescriptive. There's a lot of space for professional judgment, and requires the professional judgment of physicians and MAiD providers, which I'm sure we'll hear a bit more about. So Bill C7 did come into force last Wednesday, very kindly in time for this event, so that we can discuss it with a little more certainty. The headline change that's gotten a lot of attention is that a person's death no longer needs to be reasonably foreseeable for them to be eligible for MAiD. And this decision, this was mandated to the legislature in a 2019 court decision that found that that criteria was a charter violation, so that it was infringing both the Section 7 and Section 15 rights.
So that basically means it limited someone's personal autonomy.
Yes, their autonomy and their equality rights of access to that service. So that was the task given to the legislature, but they did also deal with some other really important things that I think are going to, gain more attention maybe as time goes on. So we see the new two-stream system for people whose death is reasonably foreseeable. They have a bit of an easing of the safeguards that need to be in place for them. I think really importantly, including the potential to waive the 10-day waiting period, but also the final consent waiver. I feel like we'll end up discussing that a bit tonight as well, because I haven't seen it discussed that much, and that's one of the things I'm most interested in looking at this new set of provisions.
The changes also herald the introduction of mental health or psychological suffering down the road. As of criteria for eligibility. Yeah.
Yes, that's true. So what we have there is we have a 2-year exclusion provision that says that for the next 2 years, it is still not permitted for someone to have as the sole basis of their application for MAiD being a mental health condition. And that's something that's been on the table for the government to deal with since medical assistance in dying first came into force back in 2016, and they haven't really done much about it in that time. So we have that. We also have a promise for a joint committee, a parliamentary committee, to review the mental illness provisions as well as advanced directives and mature minors, although there is not a provision explicitly about those that will be going into the Act at this time.
Okay, so that gives us, as it were, the highlights of the changes. We may come back to some of the more detailed provisions as we go along. Chantal, the new provisions remove that requirement for reasonably foreseeable. Nonetheless, I gather you're a bit concerned about what's in its place. These revisions don't look perfect to you.
No, they don't. And while they did remove the reasonably foreseeable natural death criterion from the eligibility criteria, they put it into what are called the safeguards and developed that 2-pathway system. So we have not lost needing to interpret the definition of reasonably foreseeable natural death, and that's going to continue to be problematic.
That interpretation, I gather, is been contained or guided by the regulations that medical professional societies have drawn up, right? There are a series of guidelines drafted for the providers, yes?
There is a guideline produced by the Canadian Association of MAiD Assessors and Providers. Yes, that's true. But for the most part, MAiD providers interpret the legislation in their own way. It's a clinical decision and clinical interpretation. And so there's tremendous variability across the country. Those of us in Ontario are fortunate to have had the AB case in 2017, which helped to clarify it to some extent. But the justice at that time stated that because it's a clinical decision and the person who went to court requested an opinion about that, he gave the opinion that her death would be reasonably foreseeable, but her natural death would have been at least 10 plus years out. So there are some MAiD providers who interpret reasonably foreseeable as death being imminent or within months, and then others who would interpret it as being 10 to 15 years from that time. So that's a pretty wide range, and a person could be found ineligible by one assessor but eligible by another assessor.
And that speaks very much to the question of access.
Exactly.
I mean, legal access, not physical access so much.
That's right.
Clancy, can I go back to you on that case? I mean, that case, the judge did hold that it was a medical decision, and that was a very important statement in and of itself, yes?
Yeah, absolutely. And I couldn't agree with Chantal more. Part of what's out there, I think, is a misunderstanding of what that phrase really means. And unfortunately, it's not defined in law. They did leave it to be a clinical decision, and it's not a clinical term either. So really, you were left, physicians, providers were left with a very unclear framework and very serious consequences if they got it wrong. And of course, very serious consequences for those who couldn't get access. Looking at the AB case, they had to do a very in-depth legislative analysis to figure out what that could mean in this narrow context. And because of the way that that provision is worded, and I know we probably don't want to get too far into the legal bits and bytes of it.
In the weeds, yeah.
In the weeds, but that there are a whole host of things that provision explicitly excludes. So you don't need a timeline for death. You don't need the death to be a direct result of a terminal illness. there are all these uncertainties built in there that people don't hear when they hear reasonably foreseeable natural death. I think everyone maybe has a concept of what that means to them, but that's not very helpful when you're looking for access on this large scale.
Don't want to go belabor this, but just before we leave it, would it be even possible to define that with any more precision? I mean, isn't it inevitable that you have to leave it up to a medical practitioner's judgment? Chantel?
I'm not sure why it needs to be in the legislation at all, frankly. I mean, it does make it much more confusing. And yes, it's a clinical decision, but if it can be interpreted as being imminent to 15 years away, again, that's just much too broad. And now, having said that, when Bill C-7 was introduced and this change was made, the Justice Minister was very clear that he said, we already have 4.5 years of experience. Clinicians, both physicians and nurse practitioners who are MAiD assessors and providers have a lot of experience in interpreting this criterion or this term, so that we can continue to do it in the way that has become standard practice for MAiD. Well, again, that standard practice can be 10 to 15 years. And in a subsequent interview, he said that it sounds like he said that the time frame would be no more than several years, or 3 to 4 years. So he's not clear about what it means. If he's leaving it up to us, we have our own, just from our clinical practice over the past 4.5 years, we have our own definition of it. And now he's coming up with another one. So again, it's a bit contradictory. And I think that's what led to the AB case in the first place. The physician who found AB eligible for MAiD then became afraid that he could be charged with murder if his interpretation was wrong. And so when the justice said that it is a clinical decision that really can't be proven or disproven, that opened it up the possibility for AB to receive MAiD, and we've used that since then. But it still leaves it as a question for us.
All right, we're not going to get any more certainty around that.
Not tonight.
Presumably, more certainty will come as time goes on, and there's more. I mean, as you said, the minister referred to 4.5 years of practice already. So the more practice, the more certainty there will be.
Well, I think it will come down to individual providers who are willing to provide for someone whose natural death might be 10 to 15 years out, and we'll see what happens.
Yeah. Heather, these are not questions that affect you directly. As CEO of a hospital, does the hospital screen a patient who comes in looking for MAiD, or is that left to the doctor, provider?
Yes, so, Women's College Hospital is a bit of a different kind of a hospital. We're not an inpatient hospital, we're ambulatory. So, when the legislation came to be, we looked at what our contribution could be to MAiD in the system, and trying to fill that gap where I think we've heard from both Vicki and Mark, where people don't want to or unable to, for a variety of reasons, have MAiD at home. So the system and the process we have here is individuals can choose to have their own physician or practitioner do the procedure. So we will credential the primary care provider, for example, to do the procedure at Women's College Hospital, or we have a roster of physicians that would complete the procedure. So people come with the assessments already completed. So we don't enter into that piece. Typically, when someone approaches us for MAiD, that step has occurred. And then we pick up and meet with the family and our team about the process, the experience that they want. We do our best to make it a little less hospital-y, but it is a hospital. And I think that, certainly for me, when I heard about MAiDHouse from the beginning, I'm here, we are all very supportive because although we are filling a role in the system for those individuals, that it's not possible to do it in their home or they don't want to. It is not what I would call a homey environment. although we've tried to make it a little bit more warm than your typical hospital room.
So you do understand what both Vicky and Mark said, that there was just an aversion to going into a hospital for this.
Absolutely. And, you know, there's lots of other reasons why people would not. I mean, I think Vicky noted the landlord. You know, we do see a number of people here who are, you know, living in the shelter system at a point, this point in their life. You know, they're affiliated with faith-based organizations that would not support, you know, so there's a whole range of reasons why, and, you know, family members who are not comfortable, even though the individual chooses to have MAiD at home, the rest of the family is not supportive. So, you know, there's many reasons why that's, you know, not the optimal choice or option for people at all.
What do you do to make it less hospital-y, as it were? Because I mean, as you're not a hospital with beds and breakfast and stuff like that. I mean, how do you create something?
Yeah, I mean, it's you know, kind of a makeshift a little bit. I mean, because the where we do MAiD is, you know, other times used as a hospital room. It's a procedure room. So we do have a different bed that we wheel in, like a regular bed versus a hospital bed. And we have other chairs that are more like lounge chairs. So, you know, we have always, you know, supported people and their families, whomever they would like to be there. So we often have, you know, other comfortable chairs, blankets, and other, you know, room decor, music, you know, the basic things that people might want when they're there, snacks, drinks, you know, that kind of thing. So
yeah.
It's
and
okay.
Just to clarify, you do take transfers from faith-based institutions that do not provide MAiD in their full 4 walls, don't you?
That's correct. Yeah.
How much demand has there been for that service?
Yeah, no, that's a great question, Karen. I don't know the exact number that have been the faith-based organizations or transfers. It's definitely been a piece of what we do. You know, I think, you know, it's evolving. We have a number of physicians right now on our roster that are affiliated with ICHA, which is the Inner City Health Associates that provide care to individuals in the shelter system. So we've, you know, that's a large group of individuals that we've been supporting through MAiD of late. And yeah, so it kind of evolves and different trends at different times. I mean, you know, we don't, I have to say it's not a, you know, a huge demand overall. I mean, I think that the majority of people are choosing to have MAiD in their home, you know, likely because there's not, you know, that many options other than hospital or home. And so, you know, whether people are aware of the service that we do is, I think, a question. We wonder sometimes how known the service we provide is. But
yeah.
it's
I want to ask you one other question before we leave all this. A friend of mine had MAiD last summer, and she lived in a rooming house. It wasn't what she wanted to have MAiD at home. And she wrote about this on Facebook. She was concerned that by going into hospital, particularly during the time of COVID, she would be using up hospital resources that were better deployed in other ways. Does that ever come up? I mean, is that more reason to have something like MAiDHouse?
Yeah. I mean, I was thinking about what I think Vicky was talking about as well, that in some organizations, you know, you don't necessarily line up all the people that are supportive of MAiD. And, you know, I think for us at Women's, the way we've done it is it's, you know, we did a call when we started back in 2017 for individuals that wanted to participate on the MAiD team, and we had an overwhelming response. So it's, you know, those kinds of things have never been an issue. But you know, I haven't, heard about the bed, but I mean, certainly bed pressures are like the top of the list in hospitals, particularly during COVID, for sure. I mean, for us at Women's, I mean, this is a values-based decision, right? This is a very important service, and when people make a decision and choose, then we need to do whatever we can to make room. I mean, it's, it doesn't, it's more straightforward in our kind of hospital because we're ambulatory. We're not used to, we don't admit people per se. It's very streamlined, and we try and, make it as uncomplicated as possible for people when they do have the procedure.
Chantel, most of your patients, do they receive MAiD in their homes, or what have you encountered as a provider?
I am a community-based provider, and so
Okay.
the vast majority of my patients do end up receiving MAiD at home, but I would say about 30 to 40% of them would rather not, or they express early in the process, where can I go to do this? And I say, well, here at home, because I usually do my assessments in the home. And they say, well, I don't want to do it here. And so then they say, well, what are my options? And I do have credentialed privileges at Women's College, so I could take them there. And so when I offer them that, well, I don't want to go to hospital. So, well, there's hotel, sometimes funeral homes. So there
Funeral
are
homes.
Yep, I have provided for MAiD in funeral home or in funeral homes, and a number of my colleagues have as well. And it's we've been fortunate that for those patients who really needed a place to go, because they absolutely could not do it at home, that the funeral homes did open their doors to us. But it's not a great option. It's certainly not what patients would have preferred. And a lot of the families and patients are quite shocked that there is no place for them. And so that's why very early on in my practice, back in even 2016, I saw a need for it and got involved when I heard from other colleagues in 2017 that they were interested in putting together MAiDHouse. And I think somebody in the chat asked, could we talk a little bit about what MAiDHouse is? Well, MAiDHouse ideally will be a home-like environment where patients can receive medical assistance in dying, surrounded by their family and loved ones, especially in non-COVID times. And it would be a place where they could go for their last hours and be comfortable and feel safe and feel welcomed.
The thing that jumps to my mind, and this goes back a way, is Casey House, established by June Callwood for patients with AIDS. And that was a long time ago when AIDS was a death sentence, as it were. Is that in your contemplation at all?
Meaning to establish a hospice like
yeah.
Casey House?
Yeah.
I don't think so, because I think ultimately people want to be able to be at home as long as possible.
Right.
And so MAiDHouse would allow them to come to a place on the day that they would receive MAiD, but then they would be able to stay at home with their family and friends and surrounded by the things that are comfortable with for as long as possible. Now, there aren't hospices in the GTA that will admit patients solely to receive medical assistance in dying. So if a patient wants to be admitted to hospice and receive medical assistance in dying there, they have to be admitted to the hospice well in advance. And then after some time at the hospice, then they can request medical assistance in dying. So for those patients, they would have to move to hospice weeks ahead of time rather than, again, spending those final weeks at home. So again, another need for MAiDHouse, because we won't need people to come and be inpatient.
I know there's certainly been discussion in the media about hospices also declining to provide MAiD. Fortunately, the hospice out here where I live does provide MAiD, permitted, and it has happened there. So I think that has reassured some people, because obviously if you're talking about MAiDHouse, that's good for Toronto. It's a big province.
That's true. And ideally over time, there will be other satellite MAiDHouses in other parts of the country that, people will learn from our growing pains and our experience, and then be able to recreate MAiDHouse type environment in their own communities. And access is certainly an issue in the more rural communities, that's for sure.
Yeah. I don't know if Vicki and Mark are there still, but I'm curious whether there was any difficulty in finding a MAiD provider. Vicky, was that an issue for you or Mark? Or was it a well-oiled?
No, I simply looked up under government services and searched for MAiD, and it came up, and had a phone number. I put a call in and said my husband's interested. He's called Mike back. The next day, a nurse called back and asked him questions to make sure he was of sound mind, and said, fine, the doctor will be there. We'll call you in the next couple of days. She called and said, I'll be there in half an hour. I was at work, so I said, fine, I'll head home now. So,
Wow.
so it was, there was no big, right? So it was great. And the problem we had was that he didn't have a date at that point. So he said, I'm not quite sure when, but I know it's in the near future. That was before Christmas, and we had the second doctor come in, and both were charming. And then we moved to, as was required, we had to get out of that place and move. So we moved to Shepherd and Young, and that was another territory. So we had to have the doctors come in again when Michael finally said, okay, I'm ready. So, because everyone has their own little territory to cover, as I understand it. Is that right, Chantel?
No, actually, I've not
Vicky,
heard
I'm
of
going to interrupt you. I just want to interrupt you there, Vicky, because you're breaking up and I'm not hearing you clearly. So forgive me if I'm not responding to what you're saying. But Mark, could I turn to you? Was there any difficulty in finding a MAiD provider for you?
We were very fortunate in our experience. We live pretty close to North York General Hospital here in Toronto, and my mom was going there for her cancer exploratory, like her testing, and
Right.
she ended up going to Sunnybrook for treatments, but North York was where she began the process, and they discovered it, and they actually have in the oncology clinic there, they have a couple of providers, and we felt very well supported. Especially, I've heard some, in my time interacting with other people who've had family members choose MAiD outside of the city, I've heard some real horror stories and just some, real gaps in the access to care and just different standards, as Chantal alluded, spoke to. But ourselves here in Toronto at North York, they were, supportive, a lot of guidance, met with the whole family, and really explained every step of the way and helped
Right,
my
it-
mom make the right choice
worked.
for her.
The system worked in that regard. Yeah.
Yes.
You mentioned outside Toronto, and I just must bring up the question of nurse practitioners, because Clancy nurse practitioners are also authorized to provide MAiD, are they not?
So yes, that's true in certain circumstances with all of the other guidelines in place, of course.
Right.
So if you're talking about access, and are we still talking about the rural setting?
Well, presumably that's one of the reasons why nurse practitioners were included, is just because of the realities of our geography.
Yeah, Ontario and Canada in general has quite a lot of rural access issues
Right.
that are in some cases being bridged by telemedicine, but this is not one that really lends itself to that.
Right.
And a lot of people will have to travel if that's something that they
Right.
want to seek.
Chantel, if I may, Chantel, I understand there's a problem for nurse practitioners in so much as they're not paid to provide this service.
That's right.
How can that be?
You'd have to ask Doug Ford that. Since the beginning, there are fee codes now for physicians that physicians can use to bill OHIP for the services that physicians provide, but there are still no MAiD specific billing codes. We're using palliative care codes, and there are no billing codes at all for the nurse practitioners. So most nurse practitioners, as I understand it, work for organizations. So they have employers. And if their employers allow them to provide MAiD or to assess for MAiD, then they can do it, and they have time within their work days to do that. they will be paid for the MAiD assessments and provisions that are done through their organizations. But nurse practitioners can also be independent practitioners. So if a nurse practitioner decides that he or she wants to provide MAiD or provide access to MAiD in their non-day job working hours, they do that completely free. And there are quite a number of nurse practitioners in Ontario who have put in thousands and thousands of hours doing this work and caring for patients who otherwise would not have had access to MAiD at all, but they do it completely free.
So that's another area where access becomes more difficult.
Yeah, a huge problem.
And Clancy, that's because of provincial regulation. So despite the fact that this is federal amendments to a federal act, the criminal code, the provincial regulation is very important in all this.
Absolutely. So Ontario has done some good work in this area, especially in terms of requiring effective referral, that sort of thing. That has been handled, if not perfectly, but it's been addressed at least by the CPSO, the college here. This is again where you see that interaction between, you have this exemption from the criminal code, but it doesn't really provide an entire system. So you then have the professional regulatory system, which is provincial and distinct to each province, even though they do have many commonalities, but they don't all address the same issues at the same time. Some are behind, some are reluctant, some have political issues that are in the way of getting this kind of thing going. And that can also affect access. So even aside from an individual professional's judgment, they also have to abide by their regulatory scheme, their provincial and college expectations, guidelines, policies.
Right.
And it's not just the regulatory provisions, it's also the provincial and territorial governments who fund the healthcare. And
Right.
so each province is different. In some provinces, as I understand it, nurse practitioners are still not even allowed to provide MAiD, because that's, even though it's legal according to the federal government, the provinces haven't allowed them to. And there's a wide variety of payment mechanisms for both physicians and nurse practitioners across the country. So it's very uneven.
So we have universal health care, but not quite.
Right.
I mean, I'm
Well,
sure there's other areas where that's
a lot of this universal health care is provided by physicians to some extent, but certainly nurse practitioners offering these services because we believe that they're important to provide for Canadians, even though we don't get paid for the time to do it.
Okay. I want to ask you all about one other area. The disability community has voiced concern again that the taking away of the foreseeable death criteria will make it easier to exploit vulnerable people. And I guess there you have to turn to the question of safeguards. Clancy, what are we looking at there? What are the safeguards?
Right. So this is a bit of a fraud issue, and I'm sure that that Chantal will have quite a bit to say about it as well. I think that there are a lot of assumptions being made in an argument like that about the ability of practitioners to make these judgments. Even without this change in the legislation, the provider is not just a gatekeeper, they're also protecting their patient from influence of other people in their lives, and it's their job to make sure that they're making a free and informed decision and not being subject to coercion. So that safeguard has always been present and remains present. I also think it's really important in the context that C7 comes about, Bill C7, that the disability community is not a monolith, and that these changes came about because of the really relentless self-advocacy of to people who wanted to access this service and who were certainly very capable and made that argument well and were vindicated by the courts.
Are you're referring to
Mr.
Jean
Truchon
and
mhm,
Nicole
and Ms.
Gladue?
Gladue, yes.
They brought the action in the Quebec courts.
And
And I
that's sort of been the pattern of MAiD throughout its short history in Canada, is that there are individuals who have really fought for their right of access, and that the rest of us have gained access through their struggle. I just want to recognize that, because it really, I think that it's not as cut and dry as one side is for, one side is against.
And just a footnote that, if I may, I think Ms. Gladue had post-polio syndrome, and Jean Truchon had cerebral palsy. So would definitely be seen as people who are part of the disability community.
Yes, thank you for adding that. So I also, within this same line of argument, you have some people who are very concerned about the option to waive the 10-day waiting period and that's for people who do have a reasonably foreseeable death. For those who do not have a reasonably foreseeable death, there is a minimum assessment period of 90 days. And they have to have 2 expert assessments. And there are some additional requirements in there as well about considering alternatives, considering things that would perhaps be options to remediate their suffering. And I think that, and I certainly hope that going forward, it's seen that the community of MAiD providers are out there really advocating to get those services to their patients if there are services that would help that person make a different choice. No one wants to have to be in a position of providing MAiD because they can't get their client housing. And I do think that that's a significant issue, but it's not reasonable or fair to deny people a right to a medical service for that reason.
Right, so that there are a variety of financial and social services that are putting pressure on people, and that was a completely different issue. I want to remind people that we will welcome your questions in a few minutes. Please type them in to the Q&A function, and we will get to those in a moment. Heather, can I ask you one thing that relates to disability, if you like, but not necessarily, and that's palliative care. Now, because Women's College is an ambulatory hospital, do you have a role in talking about palliative care to a patient or not?
Yeah, I mean, certainly we have many programs that where there are people that are entering the palliative stages of their lives, but we ourselves do not provide that service. So this is where, you know, the network exists, and we would connect people with palliative services, whether they wanted them in the home or they needed to be into hospice or hospital. But yeah, so it is part of the conversation.
So, and the hospital gets involved in that as well as the primary provider?
Yes, that's correct. I mean, it, you know, not, you know, it depends, I guess. You would say typically it would be the primary care provider, absolutely. You know, and we have a number of specialty programs where, you know, people are dealing with other, you know, diseases, et cetera, that would put them into the palliative space, and it could be a specialist, you know, an oncologist, some other kind of specialist that might be having those conversations with people. You know, it tends to happen where, you know, who's delivering perhaps the message, who's been working most closely, the relationship with the specialist, the relationship with the primary care provider. So it can happen in a number of different ways, that conversation about moving to that palliative stage of life.
And I just want to throw one thing in here. There was a Health Canada survey of the first 3 or 4 years of MAiD that indicated, I think, something like 90% of people were offered palliative care and declined. So that the indication is that palliative care option was very much there. And I know that has also been a concern of some of the opponents of some of these changes. Can I move on briefly to that forthcoming issue of mental health, psychological suffering? Chantel, how do you see that being handled? And do you anticipate that that will be a discussion that you end up having with your patients?
Certainly. And over the next 2 years, during this sunset period, the government is going to be putting together safeguards that will guide or mandate how medical assistance in dying can be provided to people whose sole underlying condition is mental illness. But I think it's an important conversation to have, certainly as a provider with somebody who has their sole condition being mental illness, to really understand and explore with them what leads them to want to seek MAiD. And I think that there certainly are some irremediable mental health conditions that lead to tremendous suffering over a very long period of time. And people suffering in that way should be allowed the right to choose a dignified death and not be forced to suffer for endless years of repetitions of the cycles of their mental illnesses.
And that presumably is the area where most suicides occur.
I'm not sure. I mean,
perhaps I'm overstating.
I think suicidality is different from choosing MAiD. And I think this is something that's really important, that a person in the throes of suicidal ideation, or really severe suicidal thoughts, and even who may be at risk of impulsively committing suicide, it's a very different scenario than someone who is choosing MAiD. So, there a lot of times the opposition to MAiD for people with mental illness as well. So my 17-year-old son could choose MAiD because his girlfriend dumped him and he got depressed and was suicidal. Absolutely not. Absolutely not. And that's part of the assessment responsibility of the assessor and the provider, to make sure that the person's request is a rational request, that it's sound, that it is a clear and consistent request, that it's in keeping with their personal values and ethics, and that it's not an impulsive decision, not made in the throes of a mental illness. And if there's any doubt, then they're not eligible, and you reassess and reassess over time. So I think the kinds of horror stories or the fear mongering that's happening around that is very destructive and does an injustice to people who suffer egregiously from mental illnesses.
And I think that same Health Canada study said that something like 25% of MAiD requests were not accepted. So, I mean, that does happen. People do say absolutely not. Right. And have you said that?
I have, yes. I have had patients whose sole underlying condition was a mental illness, and I've had to say, I'm sorry, you are not eligible, maybe one day. And as a result of C7, those people are going to come forward again and will want to be assessed and be ready, so that when the sunset clause happens, that they will be able to access MAiD. And I think there's a certain amount of concern amongst MAiD assessors and providers about what that's going to mean for our practices, and how will we assess capacity, and how will we assess the request for medical assistance in dying in the context of mental illness. And I think it may be more complicated and certainly will be tricky in certain circumstances, but I think it's very doable. And over time, we will develop an expertise with doing that as well.
The one area that was not included in the new legislation, I'm sure there's more than one, but the one notable one that was an amendment was put forward when the bill went to the Senate the first time by Senator Wallin. And that was the question of advanced directives, which is something that I think concerns a great many people because it pertains to dementia. How do you see, I mean, I'll ask Clancy, how do you see that one going from the legal point of view?
So while we're on the topic of consent, I think that's really a big part of the question, because the way our system is set up is you need to be able to consent to treatment, or someone consents on your behalf. And right now, I think reasonably substitute decision making is not permitted for MAiD. But you do need a contemporaneous consent. So this is part of why I think it's so interesting that they put in the final consent waiver and the ability to set a future date with a physician once an assessment has been completed, so that if in that period the person loses capacity, they can still receive MAiD under certain circumstances. And that is a really big change. And especially from a consent and capacity point of view, which is a lot of what I work in, I think it's exceptional and bodes very well for the possibility of at least considering advanced directives, or moving toward some concept where we're not forcing people to make a decision earlier while they're capable, so that they don't fear losing the opportunity because they've lost capacity. And that's a very real tension. And I think that those who value life and value their time with their loved ones would be very responsive to that issue being addressed.
Chantal, is there anything you want to add to that?
Yeah, I think it was wonderful of Senator Wallen to introduce that amendment, and I was really thrilled when the Senate passed it and extremely disappointed when the House just dismissed it out of hand. I think this is something that Canadians have been asking for clearly and consistently, even before Bill C-14 came into effect. And I think more than 80% of people favor advanced requests for, even if you don't have a diagnosis. And I know many, many people who would like to be able to create an advanced care plan, including a request for MAiD under certain very specific circumstances, so that, you know, and an advanced care plan is not something that's written in stone. It's something that's revised over every several years as you get older and as your needs change and as your preferences change. But if you have somebody who has an advanced request for MAiD, and they've included that in their advanced directive, year after year, revision after revision, you have a very clear pattern of that's their belief system, that's their value system. It's a clear and persistent request for MAiD under specific circumstances.
Right.
And they don't have an opportunity to put that forth now. And I think that that's most unfortunate. It really, that impedes access for people.
There are very few jurisdictions in the world that accept advanced directives, are there not? I mean, I think
that I don't know.
Yeah, I think Belgium does, and maybe Holland, and that's about it. Heather, do you hear that one discussed in your hospital? I mean, advanced directives and dementia and things of this nature?
It's always a discussion in healthcare, you know, regardless of the setting. You know, people, you know, understandably want to articulate and have some control in the future. And when people are diagnosed with things that, you know, where you have a sense of, you know, what might be your outcome and or just future planning, I think it's a constant conversation, and absolutely people certainly want to have MAiD as one of those options in their advanced care planning.
Yeah,
a natural extension of a you know, a robust plan for those.
The other thing to note, Karen, is that if someone has already been diagnosed with dementia, dementia is a terminal condition. And so someone is diagnosed with dementia, their death could be seen as reasonably foreseeable. And so they may not even need to have an advanced directive. I'm really talking about it for people who are younger and healthier, but who want to include that in their planning in the event that they develop something like dementia or Huntington's or MS or various other conditions where they would want to, again, have it clearly set out consistently over time that this was their wish, or for somebody who had a massive stroke and then became incapable. You know, that you can't predict when something like that is going to happen, or a severe accident in which somebody has lost capacity. And could be left to live existing in a hospital for a very long period of time.
Yeah,
Karen,
thank
if I could, just because it really strikes me in the advanced care planning that we are permitted to do now, that there are things we are allowed to request that put an incredible burden on healthcare providers, and that, for example, we can refuse artificial nutrition and hydration. That's a very slow passing. And I think there's a disconnect in these concepts where we're permitted to do the one, but we're not permitted to make an advanced request. And I think that tension needs to be resolved at some point.
Yeah, there's a great artificiality about that distinction. It defies logic. And I'm reminded of the case of Margot Bentley in BC, who suffered for 17 years with severe dementia, and wrote in her advance directives that she would refuse food, etc. However, the hospital would not permit that to take place. I mean, that still happens, does it not?
Yes, it does.
Yeah, yeah. All right, I want to go to questions, and we do have questions coming in. Heather, here's one for you. From entry into hospital, how long does MAiD take? And this question is for the family, I suppose. What's the process?
Yeah, so it's a great question. I think I said earlier, we do like to try and keep it as uncomplicated as possible. So when the family and the individual who's having MAiD come in, we can get started when they want. So we don't have a time frame. We, allow people to take as long as they want before the procedure, after the procedure. I mean, there's of course logistical issues around, the coroner and the funeral home and et cetera, but in different individuals and families choose different durations, but that's part of the conversation that we have with the family in advance of the planning with the provider to determine what's the experience that they are hoping for and they want.
So flexible.
It's usually we've had a few, quite long ones, but I would say generally speaking, it's, it would be a few hours.
Right. Somebody asked, how has COVID impacted MAiD? Chantal?
Well, early on in COVID, actually, access was difficult because some hospitals did close their MAiD programs and people were not allowed to have MAiD in the hospital, in part because of the issue of resources. So that was within the first 6 months of COVID, and that has certainly eased up. The challenge of going into long-term care facilities where the COVID became very widespread put people at more risk. And so it was difficult for people who were in long-term care facilities or retirement homes who wanted MAiD, difficulty getting access to their families, difficulty getting access to assessors and providers who were able and willing to go into the facilities, that kind of thing. I think there are certainly some patients or some people who were planning on MAiD at some point, but not necessarily right away, who decided that with the restrictions of COVID made it so impossible that they weren't able to see their loved ones or do the things that they otherwise would have been able to do. And as their conditions got worse, they said, why should I continue this? So people chose MAiD to perhaps earlier than they otherwise might have. And then another thing that we don't talk about all that much is access to medications. The medications that we use are also the medications that are used in ICUs and would be needed for intubation and that kind of thing. So there have been medication shortages and difficulty getting access to medications at times.
Can I ask you, have sessions being developed for MAiD providers that instruct you in best practices? How does that work?
Well, I mean, those of us that started out in the beginning taught each other and learned from each other, got consultation with people who were familiar with using the medications. Some early providers went to the Netherlands and went to the US and actually spoke to people there, got access to their information, and then they've shared it widely. And that group of physicians was mostly centered in British Columbia, and they also formed the Canadian Association of MAiD Assessors and Providers back in 2016, and we've been helping each other since then. And now CAMAP has a series of guidelines and medication protocols and that kind of thing. And each of the provinces has their own medication protocols and ways of doing things. And some of the medical associations also have stepped up and done some training programs. But I would say the expert body would be the Canadian Association of MAiD Assessors and Providers. They are really the ones that have championed the education of clinicians and the education of the general population for learning about how the MAiD procedures are done. And I have to say, Dying with Dignity Canada was absolutely instrumental in getting us all together in the beginning. You know, they connected, they knew physicians in different parts of the country, and they put us in touch with each other. And that was really the origin of the national network, which CAMAP has become. And CAMAP and Dying with Dignity still collaborate very closely on regular educational seminars for clinicians. For example, every month we have a case sharing webinar where clinicians across the country will present cases and situations that we have had that we think others can learn from, or that are quandaries for us that we're stuck with and don't know where to go with. And so we present them and get advice from our colleagues.
I wonder too, if as a MAiD provider, you collectively have particular need for mutual support in what must sometimes be very difficult circumstances.
Absolutely. And I would say the community of MAiD assessors and providers and those who support us are amongst the finest community of people I have met in all of my years of medicine. Incredibly supportive, collaborate, generous, giving, both to their patients, but also to each other. And I don't think we could do this work as much or as intensively as many of us do without that support.
Right, right. Another question. How many, well, I don't know if anybody has a number, but the question is, and I suppose it's to you, Heather, how many hospitals allow MAiD? I mean, what's I suppose the best one can ask for is a ratio or percentage.
You know, I don't know the answer to that. I mean, it is legislated, so all hospitals should be providing it. Of course, we know the faith-based hospitals do not, but I don't have, Chantel probably knows better than I do. I certainly know in Toronto, in the downtown core, it's available. I don't know much beyond that.
Chantel?
I don't have any new data. I mean, very early on, I called all the hospitals, the GTA, to try to find out about their MAiD programs, and most didn't have any and weren't allowing it. And that has certainly grown. So I do think that all of the major hospitals in the GTA do, except for the faith-based ones, and probably across the province as well. Most of the hospitals that are not faith-based would have some kind of MAiD program or access to MAiD, but I don't know the statistics anymore.
Right. I know that out here in Northumberland County, in the beginning, the local hospital here was sending people by ambulance to Peterborough to have MAiD. So I think these things took a while to come into place. Somebody asks here from this area, could you tell us a little bit more about what MAiDHouse might look like, what it is? And I guess, again, that's to you, Chantal.
Well, actually, I would say that's more a question for Tekla.
Oh.
I mean, my hope is that MAiDHouse will be a warm and welcoming environment where somebody can go and receive medical assistance in dying, that it will be like walking into a comfortable living room / bedroom. There will be different options. I think many people want to be sitting up in a comfortable chair or on their sofa to receive MAiD, and that's quite fine. And patients are often surprised when I say, you know, you can be pretty much wherever you want. You can wear whatever you want. You can eat and drink whatever you want. And I've had patients who are sitting up in what to me would be a very uncomfortable looking chair, but it was their favorite chair and they wanted to be seated in that chair facing a particular thing in their apartment, and that we made that happen. So it's again, it's something that would be comfortable and comforting for people.
And I mean, to be banal, how big would you think it would be? How many rooms might it have? Have you got that far in your thinking?
I think that depends on how much funding we can get. You know, we will not be charging patients or clinicians for the use of the space. So and MAiDHouse itself will only be providing the space. The patients will come with their own clinician provider, and again, so we'll be providing the space free of charge. And it really, we rely on donations to make all of this happen. So we're going to be doing active fundraising, and we will have to fundraise every year to meet our expenses. So I think initially we'll probably start out with one space for a procedure, so that there would be one procedure done at a time on the premises.
Right.
And my hope is that it would be a big enough and comfortable enough room that a patient would feel comfortable with their family and friends coming to, again, post-COVID, have a celebration of their life, and the people that they love and care about could be around them and feel comfortable. I mean, I have provided in some pretty cramped quarters that were filled with people, and this is even during COVID, because that was what was available for people. And so we're just, I want it to be a comfortable place where people can have a dignified death and feel really good about it.
Well, and not only would you have to raise funds, will you have to raise funds, but you have to find a place. Right?
Yes, we do.
Physical facility,
Mhm.
which is not proving easy.
That has not been easy. And again, Tekla would be better to speak to that, and perhaps she will talk about it at the end. But she and our project manager, Mona Kornberg, have looked at many, many, many locations and have found a number that would have worked quite well, but the landlords were not prepared to rent to us for the purpose that we are going to
Right.
be using it. So it has been challenging.
Forgive me, I have to peer in closer to the computer to read this question. A question from Maureen Taylor, who is a physician's assistant at Michael Garron Hospital, I believe, and has been active on this issue for a number of years. How should those of us who support C7 respond to those who say things such as, we shouldn't be expanding access to MAiD until we've, one, provided adequate palliative care to everybody, and two, provided adequate supports and resources to every disabled person? What's the response to that? I'll ask Heather that.
Well, you know, I mean, this is where we get back to individual values, right? I mean, I've always of the mind that, you know, you can't, you know, people need to make their own decisions. When the legislation has passed, it's the law. And, you know, for me as a, you know, a servant in the healthcare system, it's our job to fulfill on what the legislation says. So, you know, I'm not sure you can convince people necessarily who don't align with your view. That would be the way I would take it. Chantal or Clancy may have a different perspective.
I agree. I don't think we're going to change people's minds, people who are adamantly opposed to MAiD. But in doing the MAiD assessments, you know, I have to say, I ask all my patients, what would lead you to change your mind and not want MAiD? Nothing, absolutely nothing. And I go through the list of, you know, when we do our assessments, we also want to look at, are there things that perhaps the patient has not tried, they didn't know about, that might alleviate their suffering enough that they might seek an alternative to MAiD? And, you know, patients get angry and roll their eyes when I start going down the list of things that they could try. But I have to make sure that they know about them and have clearly rejected them. But I would say 99% of my patients have not wanted, they don't even want to hear about it, let alone make that choice. That I'm done. I want MAiD.
Had enough.
I've had enough, and that's what I've come to. So I think that has to be respected. And as Heather said, each person comes to the choice of MAiD through their own life circumstances, and they're the ones that get to assess whether it's a choice that's good for them. And in an ideal world, we would all have access to all kinds of supports and adequate housing and adequate finances and all of that. But people live in their own individual worlds, and they don't want to be patronized and told, you can't receive medical assistance in dying because we don't think that you have tried enough treatments, or we don't think you have lived under good enough circumstances yet. And so you have to wait until you have better circumstances before. People don't want to hear that.
Just a footnote, I know when the Belgian Parliament brought their law into effect that permitted their version of medical aid in dying, they simultaneously introduced legislation that provide for universal palliative care. The two things came in simultaneously, so that argument could not be raised. It was there, it was all available. What else have we got? When can we begin to apply the new legislative changes? Can we dispense now with the 10-day reflection period for reasonably foreseeable deaths? Bills, Clancy, the bill's received royal assent, hasn't it?
Yeah, royal assent. It's a go.
As of March 17th.
Yeah.
We've been applying it already. Yeah.
Okay, so well, that's pretty straightforward. I'm looking at, apart from some of the specific atmospheric factors mentioned in the testimonials and by the panelists, I am curious as to the reasons some do not want to have MAiD in their homes when so many people say they want to die at home. Now, Mark, can I turn to you because you have been through that? Is there anything else? There's a reason why people don't want to have MAiD in their homes that you can think of.
Certainly. So not only the physical environment, but also the other people who might be living in the space. So, and additionally, the people who live in the house afterwards. So I have personal experience where, you know, my mom, not only did she not feel comfortable in the house, but one of my siblings was there, and it just was not, he was not in support of her MAiD choice. So it just made for not a good space on many levels. And then in my work as kind of facilitating MAiD support groups, there have been people who have experienced MAiD in their homes, so a parent or a spouse, and they're left with these constant reminders of their loved ones who died on their, for example, their living room couch or in their TV room. So it's a family space, and now it's been, for lack of a better word, kind of tainted by this experience of MAiD happening there in their home environment.
No, it's a good answer. Good answer. Can I add one more thing? That the point has been raised that, and this is horribly crass in many respects, in this heated real estate market, there are some cultural sensitivities that say they do not want to purchase a home where, and I appreciate the distinction, but where a suicide has taken place and that MAiD has been interpreted in that way, even going as far as to put that in an offer of purchase, asking the buyer, the seller, to warrant that hasn't happened. I mean, it's a little mind-boggling to think of that. Have you heard anything of that nature, Clancy? Can you see that as being possible?
No, I'm not a real estate lawyer, but I had not heard of anything like that occurring.
Yeah, the Real Estate Council of Ontario does write about stigma and the duty of a real estate broker to ask those questions to the seller. So,
I've certainly heard that from patients and families who do not want to have MAiD at home.
Right, right. Sorry, somebody has written in and said, I think it's over 140 different hospitals in Ontario that now permit or provide MAiD. There's another person listening who extends thanks to Chantel for your services. In the future,
My people.
in the future, if advanced directives were allowed under MAiD, how might this look for a dementia patient? How would a patient define when it would happen, when dementia doesn't follow a linear path? How would a doctor perform MAiD on someone who was scared of a doctor? Not a bad question. And Chantal, I think we're back to you again.
Well, yeah, that's a tough one. It is a good question. And, these case-by-case assessments are really important. And part of it is the time that the assessor or provider takes in spending with the patient and with the family and getting to know them and letting them get to know us as well. And it is a relationship. It's over a relatively short period of time mostly, but it's an incredibly intense and personal and intimate relationship during that time. And part of my job is, again, I talk about my patients and their families as my people. They are important to me, and I want this to be a good process for them. We only die once, and I want it to be as good as it can possibly be. So there will be lots of questions and exploration of what their circumstances are and what their situation is and how to make them as comfortable as possible with that. And, for somebody with dementia, if they're frightened of doctors and, but they still have the capacity, or up until now, they've needed to have enough capacity to be able to choose MAiD. There would have to be enough of a conversation where people would feel safe enough with the provider to be able to set that up and to go through the MAiD process. And I think it's also important to know that even with Bill C7 and the waiver of final consent, if somebody did lose capacity and that it was possible still to provide MAiD for them, if in any way they demonstrated through word or gesture on the day of MAiD that they didn't want it, it stops. We go away. The whole thing stops. No one is going to be held down and forced to receive MAiD who doesn't want it. And so I think that's another thing that people get quite frightened about.
Yeah, thank you. Clancy, will you or your firm be getting involved in the parliamentary review on issues like advanced directives?
I don't think so. If there's an opportunity for public comment to go in, which there sometimes is, I would certainly consider that, but it's not something that we've discussed as a firm.
Right, fair enough. And one last question to anybody who chooses. Do you see MAiDHouse as being in conflict with hospices? Chantal, here we go again.
No, not at all. Because again, hospices are places where patients would go to actually live because they either can't stay at home or don't want to stay at home for their dying period. And so MAiDHouse, again, just as a place for the MAiD provision alone,
Right.
I don't see that in
Okay.
competition at all.
Tekla is appearing before us.
Mm.
And I think we're reaching the end of our session. Quickly, is there anything anybody else would like to add before we close? If not, I would say thank you to all of you very much for participating this evening. And I think we've had a good discussion. Over to you, Tekla.
So as Karen said, and I said at the beginning, I thank everyone for joining us on this discussion. As the Executive Director of MAiDHouse, I look forward to carrying on these discussions. And these discussions are happening, as Chantal mentioned, with other organizations like CAMAP and Dying with Dignity Canada, as well as Bridge C14, who provides grief and bereavement support. Mark has set up a peer group, and that has been taken up with other people. So there are different resources available. You will see in your chat box a link to a poll. Please, I encourage you to fill that out. Let us know how we did at our first virtual event, as well as give us ideas for what we will do at our next event. In addition, I'd like to just say a big thank you to Karen as the moderator. As I said at the beginning, she shared her wealth of experience in helping us pull this panel together. And to the panelists, Mark, Vicki, Clancy, Heather, and Chantal, a particular big thank you to Mark and Vicki to share your journeys with your loved one. Access is really important. We look forward to establishing the space for MAiDHouse as what was raised in the panel It is actually less about the budget and more about finding a landlord who is willing to host us. We have been told that people will not rent to us because they are worried about the devaluing of their property. So we've had that experience firsthand. And behind the scenes, you will have seen a slide that said MAiDHouse. I'd just like to give a shout out to one of our board members, Blair, who is the chair of the Communications Committee. She has been helping do all the behind the scenes, the chat, and pulling out that great invite that we were able to promote. So as a volunteer organization, we look forward for you checking out our website. If you're interested in volunteering or becoming a part of us, please let us know and enjoy your evening. Thank you so much, and please do fill out the poll. It's really important information for us. Thank you and good night.
Thank you all.
Thank you. Good night.
Thank you.